gears a little bit. I know we could have, this always happens every time I talk to all of you experts. We have all this agenda lined up, but like we sort of soon realize we're running out of time. Why don't we shift gears a little bit in the last 5, 7 minutes or so? Talk about, some of your programs you're working on, the primary care-based skin cancer screening program. What is that? Like how you
Yeah, so figuring out the best way to detect melanoma is really challenging because we can't just say everybody in the US go see a dermatologist every year. We don't have the workforce. Not everybody has access to dermatologists. Not everybody's going to do it, is going to actually show up. And we probably that's probably not the best way to approach this. So what we realized, however, is that a lot of patients do see a primary care physician, and that sometimes primary care physicians, their training in dermatology is extremely limited. You can go through medical school without ever taking a dermatology elective. So there's a lot of knowledge gaps in primary care about what melanoma looks like. And so we decided that, one way that we could try to address this is one, just to provide some information on skin cancer, training on how to detect skin cancer, but really with a focus on melanoma to our primary care colleagues. They are often seeing patients for an annual exam and say, while they're there, now that we have, kind of given you this knowledge about melanoma, we would like you to look at their skin as part of their routine physical. Not going to be like what you do. It's not going to involve confocal microscopy. It's just going to involve a quick look to make sure that we're not missing anything. So we did that at UPMC. We trained our primary care employed physicians how to recognize skin cancer, and then asked them to do a skin check in patients who were 35 and older once a year when they were in the office for routine care. So it's not adding more visits, it's trying to make that part of the routine visit. And so then we went and looked and said, so we've got people who are a big group of people who are eligible, over 600,000 people. And then, some of them are going to be screened and then some of them are not going to be screened. And then we looked through using our electronic medical records, looked at the melanomas that were diagnosed in those patients. And so what we found was that, we had more melanomas identified in the groups who were screened than those who were not. What we saw really was a lot more thin melanomas in
yeah.
the group who was screened. So what does that mean? I mean, we think optimistically, we're finding early curable melanomas. Hopefully, we're going to impact survival. We've looked out to 5 years. We don't have data on on survival. So I don't have data to say that worked. We saved, this,
Laura,
that.
I'm going to interrupt you for a second.
Yeah.
Just curious, like, how did you train? What do you teach those primary care physicians? More importantly, whatever you teach those primary care physicians, can those be translated and teach the general public? Because, we tell our patients to do self-exam. You talk about the ABCDs, E's, and we talk about the ugly ducklings. Is that the same thing that you're teaching your primary care folks?
That's what we're teaching them. The other thing that we are doing is actually trying to use a lot of images. So a lot of photos
Yeah,
of this is what different
yeah,
melanomas look like.
yeah.
How could we incorporate that into patient care? I actually think giving patients more pictures of melanoma so that they see, what does melanoma look like? And as we know, it can look like many different things.
Just pure clinical images, not dermoscopy,
Yeah, no, not
just pure
dermoscopy. We
clinical.
didn't focus on dermoscopy with our PCPs either.
Okay.
But that's asking them to do a lot. These are people who are trying to do a lot in a short
Yeah,
time.
yeah. They got
They've
like
got to think
seven
about it.
problems basically.
Yeah.
That is, yeah.
So, right. So the idea isn't find every early, possible dysplastic nevus. The idea is don't miss the melanoma that, could have easily been seen while you were listening to the heart and lungs, for example. So we focus on kind of big picture, knowing the diverse presentations of melanoma. And, now we're trying to focus on things like recognizing melanoma in skin of color patients, right? So most melanomas are going to occur in non-Hispanic whites, but we know that they present later in our patients who are Hispanic or Black or Asian. And so we want to make sure that we are showing them that melanoma can look different in those patients. So the idea is kind of more taking the opportunity to find melanoma when they're there than trying to set up separate visits just for screening.
Yeah, yeah. I mean, I think you're right that we just don't have enough dermatologists, number one, right? And there's some study that show that in some places, you try to call a physician's dermatologist office, talking to them about bleeding lesion, and sometimes the wait time to get in is like 6 to 8 weeks. And no, you basically touched about something really interesting. So you basically show those primary care physicians lots and lots of images of melanoma, right? But do you also show them some other images, benign lesion like seborrheic keratosis? Because one of the things the patient always come in is like, I got this really dark lesion right here, but it always turn out to be seborrheic keratosis or something benign.
Yes, we do that. So our training has modules on, mimickers of melanoma too. So we show them, seborrheic keratoses are a huge one. I try to educate my patients on that too. I think it's really hard because they do meet ABCD criteria.
Yeah,
Um,
definitely.
but yes, we do also that, show them things that are benign. What does a normal mold look like? What does a, maybe slightly atypical mold that's not concerning look like? What does a seborrheic keratosis look like? What does an angioma or vascular growth on the skin look like? So that's been an important aspect too. Now I think we're, maybe we'll be able to advance this as a field is hopefully we'll have tools that are, inexpensive, easy to use, that use, artificial intelligence
Yeah.
to look at an image and maybe give the primary care physician more feedback so that they can then say, I can safely reassure this person they don't need to see dermatology, or this is a lesion that really does need to get in, so that they can help us in triaging.
Yeah, one of the thing I'm doing here in our institution, Hoag, is that we're launching this like what I call derma on demand program. Essentially, we're giving a scope, dermoscope with iPhone attachment to the primary care folks. And if they see something worrisome, they take a picture of it and then we will review it on our end. So that way save a patient a trip. But it's also very interesting. You touched upon something that is we probably don't have time. Hopefully, like next time I invite you back, hopefully you will join us again to talk more about artificial intelligence. I know you did a lot of those works, and I mean, I think this is another one of those technology that's going to really change the way we detect skin cancer.
I
Um,
agree. I know you've done work in that area too. I think that that's going to be really exciting. And I think figuring out where to use it. Is it in the hands of the patient? Is it in the hands of the primary care physician? Is it in the hands of the dermatologist? And so I think we've got a lot of work to do to figure out. There's a lot of great, computer scientists out there who can build the algorithm. I think it's going to be up to us to figure out how to best use it in our patients.
Yeah, and also not only that, it's about the workflow, right? And how do
Yeah.
you, because what just one thing you can imagine that if you have one of those artificial intelligence device, scope, you can theoretically give it to your primary care instead of for them to learn it, they can just basically put that machine on every device. It's almost instantaneously what can tell you like yellow, like a red, green, and yellow give you those signal, right? So those are the things, and there's a lot, very, very exciting. I know, like all of us are working on this.